Yeah, looks good now.
Okay. I'm audible? I'm audible?
Yes.
Okay. So good evening and welcome to all delegates. We are starting our third webinar, HFF webinar on cardiomyopathy. So today we have distinguished speakers and panelists to enlighten us on dilated cardiomyopathy. So I welcome two distinguished speakers. Dr. Barry Trachtenberg is Assistant Professor of Cardiology, Austin Methodist, and is a faculty of Weill Cornell Medical College. So his clinical experience include heart failure and transplant. That's his core interest, and MCS, and also cardio oncology. And we have one more distinguished speaker, Dr. Vimal Raj. He got trained from Papworth Hospital, Cambridge. He's a cardiac radiologist. We all know him very well. And what we didn't know so far is he's running a European Society accredited fellowship. And he has done medical legal postgraduate degree. So all of us can take his help. And also he worked in the British Army that I didn't know before. And we have one more distinguished member here, that's Ashita Bhartur. She's going to moderate this session. She has done fellowship from St. Michael Hospital, US, and she's at present working as Associate Professor of Radiology at Jayadeva Institute of Medical Science. And we have three panelists today. Dr. Ravi Kumar is well known, a senior consultant, is a transplant cardiologist at MGM Hospital, Chennai, and he has done a large number of transplants. He's got vast experience in transplant cardiology. And Dr. Jabir Abdul Kuti is a senior consultant and director of clinical research at Lisi Hospital, Ernakulam, Kerala. Is known for his interest in heart failure. Has conducted a lot of conference on heart failure. And we have Dr. Anand Subramaniam, a senior consultant CTVS. So he also got trained for transplant and is a keen interest in the heart transplant and heart failure. So I request Dr. Ashita Bhartur to conduct this program. You have to unmute.
Oh, sorry. Thank you very much. So I'm just going to reintroduce our first speaker, Dr. Barry Trachtenberg. He's board certified in internal medicine, cardiovascular disease, echocardiography, and advanced heart failure and transplant. He received his BS degree from the University of Pennsylvania and attended medical school at the University of Texas, San Antonio. Dr. Trachtenberg, a native Houstonian, completed his residency in internal medicine at the Baylor College of Medicine prior to his cardiology training at the University of Miami School of Medicine. His clinical experience includes heart failure and heart transplantation, mechanical support pumps, and cardio-oncology. He performs diagnostic catheterizations, including radiolateral approach and endomyocardial biopsies. He has contributed to many publications related to advanced heart failure, cardiac transplantation, regenerative therapies, and ventricular assist devices. Dr. Trachtenberg is a member of the American Heart Association, the International Society for Heart and Lung Transplantation Association, Heart Failure Society of America, and the International Cardio-Oncology Society of North America. Dr. Barry Trachtenberg, over to you.
Thank you so much for the introduction and for the invitation to be here. Let me just see, can you guys see my screen?
Yes, we can.
Okay, great.
I can see you.
Okay, perfect. Well, thank you again, really, for the kind invitation to be here. It's too bad for COVID. I've always wanted to go to India and I've never been. So hopefully if I do a decent job, you guys will invite me next time when we don't have the pandemic. So thank you so much. And I'll be talking about dilated cardiomyopathy. So the objectives today, I want to review the terminology and the classifications of cardiomyopathy, discuss the role of genetics in dilated cardiomyopathy, and review the diverse etiologies and the evaluation process for dilated cardiomyopathy. So I think it's important to go back and understand where this terminology came from, which can be very confusing and a lot of overlapping terms. So the first use of the term cardiomyopathy was published in The Lancet in 1957 by Bridgen, and it described uncommon myocardial diseases, the non-coronary cardiomyopathies for idiopathic dilated cardiomyopathy. And Goodwin et al. Reported in 1980 the report of the WHO Task Force on the definition and classification of cardiomyopathies, and they called cardiomyopathies heart muscle diseases of unknown cause, classified as dilated, restrictive, or hypertrophic, and that was when they introduced the term hypertrophic. And this is from the original Lancet paper in 1957, talking about the uncommon myocardial diseases and the non-coronary cardiomyopathies. So I think this is really fascinating to me, and because this is something I always implore our fellows to dive deeper from the quote non-ischemic or idiopathic, and really try to figure out what cardiomyopathy the patient has. So even in 1957, they were demanding that every case deserves a detailed history, repeated examination, and elaborate investigation. By such means, the proportion of cases turned idiopathic should be diminished and the whole picture of these interesting conditions made clear. And I couldn't agree more with this. And it goes on to talk about the ignorance of myocardial diseases reflected in the confusing terminology. And then if you go all the way down, the etiology, even only in a broad sense, should be indicated where this can be determined, and when the cause is unknown, this should be stated. So I think it's important to go back to the history of this, and then looking at the classic morphological classification of cardiomyopathy. This is, the one we're all familiar with. You have your normal heart, you have your dilated cardiomyopathy, restrictive and hypertrophic. I think that the pros of this system are, one, it's very simplistic, easy to use. It does take a morphological approach, which I think has some value. The cons are also very simplistic. It doesn't address the etiology. There's a lot of heterogeneity of cardiomyopathy, such that patients could overlap between groups. For example, you can have a burnt out HOCM or burnt out sarcoid that becomes dilated. You can even have a burnt out infiltrated disease like amyloid that can end up being dilated. And you can have an infiltrated disease with HCM features and or restrictive features. So it certainly has limitations. Because of that, in 2006, the American Heart Association came up with a scientific statement that defined cardiomyopathies as a heterogeneous group of diseases associated with mechanical and or electrical dysfunction that usually exhibits inappropriate ventricular hypertrophy or dilatation, and due to a variety of causes that are frequently genetic. So this is the first time they really highlighted the genetic nature of cardiomyopathies. And in this system, they divided it into primary cardiomyopathies and secondary cardiomyopathies. So it was defined as cardiovascular abnormalities that were not related to cardiac muscle, such as coronary artery disease, valvular disease, congenital heart disease, and hypertensive disease. So these diseases were not considered to be cardiomyopathies. Thus, they did not endorse the term ischemic cardiomyopathy or valvular cardiomyopathy, and so forth. So if you look at the primary cardiomyopathies, they have genetic ones, they have acquired ones such as myocarditis, peripartum cardiomyopathy, and then they have mixed such as dilated cardiomyopathy and restrictive. The pros of this approach is it does acknowledge the molecular basis of cardiomyopathy. It moves away from the limitations of morphological. However, there are a lot of limitations to this approach as well. There's a lot of evidence emerging that many of these diseases that are listed here as acquired, such as peripartum cardiomyopathy, such as inflammatory myocarditis, actually have a genetic role. So if you look at patients with peripartum cardiomyopathy, a not small percent of those patients will have positive genetic variations for truncating variants in the titin gene, which is associated with dilated cardiomyopathy. Also, they have secondary cardiomyopathy such as sarcoidosis that can be isolated to the heart, and primary cardiomyopathies that can have extra cardiac manifestations. So this also does have limitations. And these are just not to spend a lot of time here, but just to show you what the secondary cardiomyopathies here are listed as. So the European approach, they kind of took a hybrid of the morphological and the genetic approach, and they defined cardiomyopathy as a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary disease, hypertension, valvular disease, and congenital heart disease, sufficient to cause the observed myocardial abnormality. So they take the morphological classification, and then they divide that into genetic or non-genetic. So really, dilated cardiomyopathy is defined as a dilatation of the left or both ventricles, not explained by abnormal loading conditions or CAD. Although, of course, we all know that CAD is the most common cause of a dilated phenotype, we don't consider that to be a dilated cardiomyopathy, which to medical students causes lots of confusion, certainly. So cardiac enlargement with typically normal ventricular wall thickness and fibrosis and a poorly contractile left ventricle. And then morphologically, it's defined by a left ventricular ejection fraction less than 45% or fractional shorting, and LV-EDD, left ventricular end diastolic dimension, greater than 2 standard deviations predicted for age and body surface area. And it's important to note that the LV dilatation typically precedes the drop in systolic function. So this chart, I think it's always helpful to have this reference. For some, we all come in different shapes and sizes, and what's dilated for one person is not dilated for another person. So it's really important to be aware of this chart that's based on gender and height of what would be considered an abnormal left ventricular size. And then, of course, I know we'll have an imaging talk later. And another way to think about dilated cardiomyopathy or to classify it is having an increased left ventricular mass index with a normal relative wall thickness. So in terms of the etiology of DCM, idiopathic should always be a diagnosis of exclusion. There are, this is not an exhaustive list of DCM causes. This is certainly a partial list, but these are some of the most common types. Certainly viral myocarditis, of which we have numerous causes now, including, of course, COVID, which is very controversial. Other infectious myocarditis causes, including Chagas, tuberculosis, Lyme disease, and a whole host of others. Toxic cardiomyopathy, alcohol, cocaine, certainly a variety of chemotherapies, which is also a particular interest of mine. Peripartum cardiomyopathy, familial, genetic, which we'll delve into a little bit deeper, nutritional disorders, muscular dystrophies, endocrine and rheumatological diseases, a lot of which will cause non-infectious myocarditis, also sarcoidosis, stress cardiomyopathy, and then delving a little bit deeper into myocarditis because there's so many causes. I think it's important to look at this. And if you look at this list, all of this should cause dilated cardiomyopathy except for the under eosinophilic. If you look at endomyocardial fibrosis or hypereosinophilic syndrome, those are in the restrictive bucket, but other than those, these are all causes of dilated cardiomyopathy. So if you look at autoimmune, connective tissue disease, and lupus, rheumatoid arthritis, scleroderma, polymyositis are all associated with dilated cardiomyopathy. Especially if you do MRIs in some of these patients, you'll find a decent proportion of them will have a dilated phenotype despite being asymptomatic. Giant cell myocarditis, sarcoidosis, and other autoimmune diseases. Then going into toxic myocarditis, certainly some chemotherapies now. Checkpoint inhibitors will cause a fulminant myocarditis often. And then, of course, infectious. And infectious is still far and away the most common cause of myocarditis. Viral infections predominate in terms of the cause of myocarditis, but it certainly depends on regions. If you live in South America, Chagas certainly is the #1 cause. So dilated cardiomyopathy accounts for approximately 20% of heart failure, but it accounts for an outsized proportion of advanced heart failure. About 50% of heart transplants are in patients with dilated cardiomyopathy, and idiopathic DCM is the #1 indication for a heart transplant. In patients that are diagnosed with idiopathic DCM, if you actually do genetic testing or do a careful family history, you will find a familial cause in as many as 50% of patients that are diagnosed with a quote idiopathic dilated cardiomyopathy. So that involves a detailed family pedigree, detailed assessment of the cardiomyopathy, including echo and coronary angiogram. And these efforts may actually underestimate the frequency because when you rescreen relatives several years later after they're initially seen, they may have their heart failure develop or have a dilated left ventricle at subsequent screenings. So most patients with familial dilated cardiomyopathy are originally dosed with idiopathic DCM. So the definition of familial dilated cardiomyopathy, and it's important to know this definition, is defined by having DCM of unknown cause in 2 or more close relatives. So if you're the proband or the patient that has familial dilated cardiomyopathy, and you have a parent or a sibling or a child that has a dilated phenotype, independent of genetic testing, you have familial dilated cardiomyopathy. And so it's recommended that you do a careful family history of 3 to 4 generations, looking for unexplained heart failure before the age of 60. So if you're having new onset or newly diagnosed cardiomyopathy after the age of 60, it's unlikely that you have a genetic cause. And sudden cardiac death, especially in the absence of ischemia, or signs of a syndromic disease, especially the muscular symptoms suggestive of muscular dystrophies. And these are some of the main proteins involved in cardiomyopathies. You can see you have your cytoskeletal proteins, you have your desmosomal proteins, connecting cells. You have in your nucleus, you have the nuclear lamin AC mutations. And then the vast majority are still going to be the sarcomeric proteins. So the troponins, tropomyosin, myosin binding proteins, myosin light and heavy chains, and of course, titin. This just helps kind of picture just how many different genetic causes there are of cardiomyopathy and where they occur. This is a little bit old. This is from 2009 Heart Failure Society practice guideline. So some of this could be updated, but generally, most of this holds true with the exception of titin, which we'll talk about in a moment. So if you look at the frequency in families, lamin AC is a common one, myosin heavy chain, cardiac troponin T. These are some of the frequencies that you'll get on genetic testing. And then of course the SCN5H sodium channel. And then this was a landmark publication from 2012 in the New England Journal of Medicine. So truncating variants in titin. Now there's been a lot of data on this, but prior to this, it really was difficult to sequence due to the large size. And they had newer techniques that allowed them to do more studies. So titin is the largest human protein. It's the 3rd most abundant striated muscle protein, and it's necessary for contractile force in the skeletal muscle and in the cardiac muscle. So they studied 312 patients with dilated cardiomyopathy, 231 patients with HCM, and they found that TTN mutations occurred in 25% of patients with familial dilated cardiomyopathy and 18% of patients that had sporadic non-familial dilated cardiomyopathy. Since this publication, there's been a lot of studies evaluating truncating variants of titin in other populations, including patients with pericardial cardiomyopathy, patients with chemotherapy cardiomyopathy, showing that there is a genetic predisposition in a sizable proportion of these patients. Genetic testing. So the Heart Failure Society guideline suggests that you consider genetic testing in the proband to facilitate family screening. Now, this is for patients that have a family history. However, it is being more common to consider genetic testing in someone that has idiopathic dilated cardiomyopathy, even in the absence of a family history. That is not certainly in the guidelines yet, and there's ongoing studies to evaluate that. But I think in terms of practicality, that is being done commonly as a genetic testing is being made more available. The Heart Rhythm Society guidelines recommends comprehensive or targeted genetic testing in patients with dilated cardiomyopathy or prominent conduction system disease and a family history of sudden cardiac death, mainly to screen for lamin AC cardiomyopathy. And I think it's important to highlight that genetic counseling should always be offered to patients at the time of testing and when results are returned. For some places that don't have that available, it's helpful to have a physician that really is steeped in the literature and the knowledge to help guide their patients if you don't have that. But it's always recommended to have genetic counseling if you can. And in terms of clinical screening for cardiomyopathy, it should be considered at these times and these intervals. So if you look at focusing on dilated cardiomyopathy today, if you have genetic testing that's negative, and if you have a clinical family screen that's negative, you should screen them every 3 to 5 years, starting in childhood. If you have a mutation present, then it's recommended to do it every year until they're 18, and then every 1 to 3 years when they're adults, up until the age of 60. Obviously, if they haven't developed it by then, they're unlikely to develop it. So just to delve a little bit deeper and make it a little more clear. So if you have a patient that has dilated cardiomyopathy and you test them for genetic testing and they have a positive mutation, then you can do cascade testing of their first degree relatives. If those relatives also have the mutation, then they deserve an evaluation, which would be a history and physical, EKG, echo. And if that workup is negative, you should repeat that in 2 to 3 years and offer testing to the next generation as well. So if you have the same patient, same proband as a positive mutation, or if you have a negative mutation, excuse me, and if you have a positive known mutation in the patient, and then you test their offspring and the offspring has a negative mutation, they don't need any more further testing. They are just as likely to have cardiomyopathy as anyone else in the world. So if you have a clear family history and you don't have a known mutation, it doesn't mean they don't have a familial cardiomyopathy. It just means we don't know the mutation. This happens in as much as 50% of patients with familial dilated cardiomyopathy that we don't know the mutation. So if they have a negative mutation, but you still clearly have a family history, then all first degree relatives should have a clinical evaluation. If they're found to have cardiomyopathy, obviously you treat that and then consider additional workup just to exclude the possibility that they have another cause of their cardiomyopathy, and then continue to test the next generation. If the family members don't have any evidence of cardiomyopathy on the evaluation, that doesn't mean you quit. That means you should continue to follow them and evaluate them every 2 to 3 years until they turn age 60 or are diagnosed with cardiomyopathy. And this is just the recommendations, level of evidence for dilated cardiomyopathy B, hypertrophic cardiomyopathy, a little more evidence A for genetic testing in the family to help family screening and management. I suspect by the time the next guidelines come around, dilated cardiomyopathy will have a higher level of evidence as there's ongoing studies now. And then cardiomyopathy is just to be aware of the systemic diseases that can cause dilated cardiomyopathy, especially the muscular dystrophies and other diseases that you can see listed here. It's just important to see these every once in a while so they're on your radar. And then just to highlight the lamin AC cardiomyopathy, because those of us in the advanced heart failure world see this fairly commonly in our advanced patients. Just to be aware that it presents with a little bit different phenotype. It typically starts off with conduction system disease, often asymptomatic EKG abnormalities, then progressive AV dysfunction, and often will have atrial arrhythmias, and then you'll have the onset of dilated cardiomyopathy. And these patients tend to be more heavily represented in the advanced world and the need for transplant. So what is recommended to work up a new onset dilated cardiomyopathy? Certainly history and exam, and I think it's really important. I always remind my fellows, to do a 3-generation family history on new evaluations. I think it's incredibly important. I think a lot of us, just due to time, we don't take the time to do it. Genetic testing, definitely if you have a family history of dilated cardiomyopathy or sudden cardiac death in the first degree relative, although you can consider genetic testing in the absence of a family history, not within the guidelines, however. EKG, and then the ones that are in bold, these are the ones that I do on almost every patient, just because of the simplicity and low cost. TSH, iron studies, ferritin, CBC, HIV, if there's risk factors, and then depending on your geography, certainly Chagas, Lyme, nutritional deficiencies, etc. And I think, a coronary assessment, however you want to do it, is really important to rule out coronary disease. Whether you want to do invasive angiography or coronary CTA, PET, stress, however you want to do it, it's important to be done. And then other tools that, and I think we'll hear a lot more in the next talk about, cardiac MRI, cardiac PET. And then I want to touch briefly on the role of cardiac biopsy. So again, just focusing on the types of myocarditis, keeping that in mind as you think about your workup and whether the patient deserves a biopsy or not. It's really important to know that histology really does matter. So even though our biopsy will be diagnostic in a minority of patients, it can make a drastic difference in those patients. Certainly, putting away the bucket of the non-dilated, such as amyloid, if just focusing on the dilated cardiomyopathies. If you look at myocarditis due to sarcoidosis, giant cell myocarditis, or eosinophilic myocarditis, these are all in a fulminant cohort in this study. You can see on the blue is the survival, or is the death, or the need for heart transplant for patients with giant cell myocarditis, compared to the red for eosinophilic and the green for lymphocytic myocarditis. You can see there's a clear increase in death if you have giant cell myocarditis. So this is one of the common reasons we do biopsies. Sarcoidosis as well as a common reason. And this is the now 13-year-old recommendations from the American College of Cardiology, American Heart Association, Heart Failure Society, guidelines for the role of endomyocardial biopsy. They went through 14 different scenarios. I think it's a great article. It's a little bit dated, but I think it's important to kind of highlight when we should consider biopsy. So I highlighted the ones here that I think are common indications that we commonly do. The other ones are pretty rare. So certainly, the number 1 and 2 scenarios are class 1 recommendations. This is new onset heart failure, less than 2 weeks with a normal size or a dilated LV with hemodynamic compromise. And scenario 2, new onset heart failure, 2 weeks to 3 months duration with a dilated LV and new ventricular arrhythmias or high degree AV block, or the failure to respond to usual care within 1 to 2 weeks. So these are really focusing on fulminant myocarditis, especially giant cell myocarditis. You really don't want to miss that diagnosis because these patients, as you know, they go down quickly. They need mechanical support quickly and either high dose immunosuppression, but more often transplant or death. So they really need, you need a tissue diagnosis. There's no other diagnosis to make, no other manner of making the diagnosis of giant cell myocarditis. Scenario number 3, a little bit less severe than the first 2 scenarios. And then scenario 4, if you have a patient with peripheral eosinophilia and heart failure, I think that's a scenario that tissue helps to confirm an eosinophilic myocarditis. Scenario 5, really not common that we do that anymore. Scenario 6, unexplained restrictive cardiomyopathy, that's mainly looking for amyloid. And then suspected cardiac tumors is another common indication for biopsy. And for those of you, I'm sure most of you are familiar with the technique or do the technique. You can go through, this is a pictorial, I like the graphic, but it's through the subclavian vein. Typically we go through the internal jugular vein or through the femoral vein, but either way, going into the RV and taking a piece of tissue. I'm not sure about India, but in Europe, it's more common to do biventricular biopsies. There's a lot more comfort with it there to do RV and LV biopsies, and they do have a higher yield for myocarditis by doing biventricular biopsies. On the bottom panel on the right, this is an example of us doing, with the help of our EP colleagues, doing a robotic guided biopsy on the patient with suspected sarcoidosis. And we've been able to do voltage guided biopsies and have EP really help us with steering catheters to help get tissue and increase our yield, particularly for sarcoidosis. And I'm sure we'll hear a lot more about this in the next talk. And for sarcoidosis, it's really, the histological diagnosis is tough. If it's just cardiac, 25% sensitivity on the biopsy. If you do voltage guided biopsies, or you might get up to 50%, but it's still a very low yield. So a negative biopsy should not discourage you from making the diagnosis of sarcoidosis. MRI and PET are increasingly used, and I'm sure we'll hear about this a little bit more. But I think it's really important to know that sarcoidosis it's the most frequently missed diagnosis in general, I think, probably and definitely prior to transplant. This is a data from the Cleveland Clinic published a few years back, showing the sarcoidosis. The 13 patients that were transplanted with sarcoidosis, only 2 of those were correctly identified as sarcoidosis prior to transplant. The other 11 were diagnosed at the time of transplant on the explanted heart. So it's really important that we use our tools to try to make that diagnosis, because even though you do treat them with goal-directed medical therapy, that and giant cell myocarditis are cardiomyopathies that have a clear benefit from anti-inflammatory medication, and so you can make a difference and avoid transplant if you catch it early. This is a great cardiomyopathy compendium from Circulation Research in 2017. Really, if you want to learn more about cardiomyopathies in general and more about dilated cardiomyopathies and their genetic determinants, there's a great article by McNally et al. And that really every type of cardiomyopathy it's a great resource for 2017. And finally, just to conclude, I think it's important that we know that idiopathic dilated cardiomyopathy, or this quote non-ischemic cardiomyopathy, should be a diagnosis of exclusion and not a diagnosis of convenience. Family history should be obtained in all patients, and those with a positive family history should have genetic testing with genetic counseling. And finally, it's important to highlight that dilated cardiomyopathy is a very heterogeneous disorder, and we should make all attempts to make the underlying diagnosis while the patient still has their own heart. And that's my final slide, and I just want to thank you guys for your attention and for the invitation to virtually be here.
Thank you so much. That was a great talk. And I'm sure if this was not COVID era, we'd ask you to take the next flight and come to India.
I'm there.
All right. So let me take this opportunity to introduce our next speaker. We'll take the questions after the second talk. He's Dr. Vimal Raj, Dr. Major Vimal Raj, a very good friend of mine. He is a renowned specialist in the field of cardiothoracic imaging. He currently heads the Department of Radiology in Narayana Health City, Bangalore. He has, he has set up a world-class cardiac imaging unit in Bangalore and performs most complex and highest number of cardiac imaging tests in the country. After completing his house surgery training in India, he immigrated to United Kingdom, where he trained as a surgeon and then took up radiology as a career. He has worked in 3 of the leading cardiothoracic centers in the world. That's Cambridge Papworth Hospital, London Royal Brompton Hospital, and Leicester Glenfield Hospital. He has also worked with the British Army and was deployed in the war zone in Afghanistan. How many do we know like him? He runs the only European Society of Cardiology accredited cardiac imaging fellowship program in India. He's a keen trainer and offers multiple fellowship programs in cardiothoracic imaging. His fellowship program gets students from India and different parts of the world. He has helped setting up multiple imaging units to perform cardiac studies in India, Sri Lanka, Bangladesh, and Middle East countries. He has a keen academic and teaching interest and has published 2 books and multiple book chapters for radiologists and clinicians. He's published nearly 80 articles in world-renowned journals. He also holds a patent in catheter design for performing postmortem CT coronary angiography. The British and Karnataka government have conferred multiple awards to him for his exemplary work. He has special interest in the field of management and has led multiple teams in both civil and military practice. He holds a diploma in the field of hospital management and postgraduate qualification in medical legal systems. Over to you, Dr. Vimal Raj.
Thanks a lot, Ashita. Thank you very much, Karthikeyan, for inviting me. And thanks a lot, Dr. Barry. That was amazing, and a lot of refresher for many of the things which we kind of keep forgetting and having to look back at our books. So the focus for today is for me to talk on imaging in dilated cardiomyopathy. And I'm going to talk about some of the specific challenges which relate to India and some of the practical applications. I'm going to do this in a manner where I'm going to be showing some real life cases, and it's going to be a potpourri of different pathologies. I'm going to focus on common causes of dilated cardiomyopathy, common causes of heart failure, which can get missed, and some uncommon causes, with the main focus of saying, how does cardiac MRI really help in these cases? Now, if we look at heart failure as a bigger group, and if we look at the general population, these are two studies which came out of US and Iceland, which showed that even in asymptomatic elderly patients, if you were just to do a cardiac MR, you are likely to find patients who never knew that they have had some form of heart failure, they've had some form of damage to their muscles or myocardium in there. And these patients tend to have a higher risk of adverse events and even mortality. On the other hand, if you look at patients who've got heart failure with preserved ejection fraction, about 1/3 of these patients who may not have anything else on the echo apart from the heart failure features, MR is able to detect some new significant pathology which will aid in the management of these patients. And again, MR was able to recognize these patients who are at a higher risk of death and any hospitalization related to heart failure. So what can cardiac MR actually do? The first and foremost thing, I think, usefulness of cardiac MR is to assess and say, is this really heart failure? Is this a dilated heart? What is the function of the heart, and what are the parameters of the heart in terms of the volume, in terms of the size, and telling us whether it is really heart failure or not. Then, when we know that the function is bad, how bad is it? Is it really around the 20%? Is it 35%? And it is important when you're assessing these patients that you need an accurate measure of the function, because we're going to be following them up on a regular basis, or you're going to recruit them on for some studies. So it's important that we have accurate measurements of their function. Again, the next question comes straight away is, what is the cause for the heart failure in these patients? And that becomes important, and cardiac MR actually solves a lot of problems in this manner. Then cardiac MR helps in management of these patients, telling us what are the poor prognostic features, which features suggest that this patient needs to be aggressively monitored, or the other way. Finally, the follow-up. With accurate measurements of volumes and function, cardiac MR really helps us in following up these patients. Now, this is pretty much what cardiac MR does. One of the best things that cardiac MR can do is to look at the entire heart, irrespective of the size of the patient, irrespective of the echo windows. We can see the heart from the top to the bottom in any angle that we want, and we can accurately assess the function of the heart. While we are assessing the function, we can look for wall motion abnormalities, and we can look and see what is happening. Now, let me bring out one case in here. This is a paper which came out quite early in 2000, which said that this is what you find. These are 4 patients who've got different heart functions, with LV hypertrophy as the most common feature, with decreased cardiac output. Now, this is what echo will tell, but with cardiac MR, when we do delayed enhancement imaging, based on delayed enhancement imaging, we can differentiate the causes of such pathology. So what is delayed enhancement imaging? It is essentially we give contrast halfway through the procedure, and we wait for about 7 to 10 minutes, and then we image the heart. We look at the heart and see for areas of white. In delayed enhancement images, everything that is black, the myocardium that is black, is normal. And depending on the abnormal area of enhancement, we can differentiate different causes of heart failure, different causes of cardiomyopathy in these patients. Now let's look at this. This is kind of a classical scenario that you come across. 2 different patients, okay, both have got a bit of dilated LV, and the function is down in both the cases. Now this, one of you may be eagle-eyed enough to pick up and say, hey, on the images on the left, I think there is reduced motion in the inferior segment across here, while this looks more like a global hypokinesis. Now, when you do delayed enhancement imaging, what it tells us easily is in this patient, this is the normal black myocardium, and this thin line that you're seeing is the abnormal enhancement, and this happens to be in the middle of the myocardium, otherwise called as mid-myocardial enhancement, a classical feature of a dilated cardiomyopathy, often an idiopathic etiology. On the other hand, if you look at this patient here, you're seeing enhancement in the inferior wall, and this is transmural enhancement, suggesting that this is an ischemic cause, and this was an infarct. So straight away, cardiac MR is able to differentiate two major groups as ischemic and a non-ischemic cardiomyopathy in these patients. Now, let's start looking at some of the cases, okay? This is one case. This was a young female who presented with a clinical history of chest pain, had a out-of-hospital cardiac arrest, got brought in, resuscitated, survived. Angios showed a RCA CTO, okay? And then we started getting history of long-standing fatigability. So we were not sure what's happening here. Why did she have a out-of-hospital cardiac arrest? And we look at this image. This is essentially showing us the right ventricular outflow tract here. And you can see that the right side chambers are dilated. Concentrate on the right ventricular free wall. You will see that it's a bit irregular, a wavy appearance. When we do delayed enhancement, again, we can see this area of infarct, which was the RCA territory infarct. The same thing, there is an RCA territory infarct at the bottom, but there is also enhancement along the RV free wall. This was a patient of ARVC. So she had arrhythmogenic right ventricular cardiomyopathy in the background. The RCA chronic total occlusion was just a red herring. It was the RV cardiomyopathy, which was basically causing her all the trouble. And then we could recognize this with MRI. Otherwise, it would have gone unrecognized in this scenario. Let's look at another case. This is a patient who came in, and initially we looked at all the functions. Fatigability was one of the main problems in him. And you can see that the muscles look a little thick, but the function seems to be well preserved. Function seems to be well preserved. And concentrate on the mitral valve, and you can start seeing that there is a systolic anterior motion of the mitral valve causing some narrowing of the LVOT, which I think Dr. Ashita must have shown you last week. And this was a case of hypertrophic cardiomyopathy. So why am I bringing this here? The reason I bring this here, this patient, when we do delayed enhancement imaging in him, what we could find was extensive areas of fibrosis. So you're seeing that diffuse brightness in the myocardium in this patient. There was extensive areas of fibrosis causing a restrictive cardiomyopathy. This again goes into lots of fibrosis and can present as a dilated cardiomyopathy at a later stage. Again, very, very important for us to be able to see that and recognize this. The next case is a third case, the 38-year-old female who had been presenting to us with recurrent admissions of heart failure. Okay, every time she comes in, we would stabilize her, she would get better and go back home. There was no contributory history at all to suggest what was the cause. It wasn't a postpartum kind of cardiomyopathy. There was nothing to suggest any stress-related cardiomyopathy. And the most recent admission, we said, okay, fine, let us do a cardiac MR. And this is the cardiac MR. And what you can see here is there is dilatation of both the chambers. The LV is dilated, the LA is dilated, and you can see mitral regurgitation. At the same time, there is tricuspid regurgitation and the RA is dilated. Okay, so we go on and we do our edema sequences to look and see if there is any edema or not. We didn't find any edema. And then we look at the function in a short axis. Again, globally reduced function. There was nothing else which was contributory in here. Then we started thinking, compared to the previous images that you have seen, the myocardium looks a little bit too dark in this case. We do delayed enhancement. Nothing much happened in delayed enhancement. But when we look at the liver of this patient, we could see that a normal liver should be something like this. It was diffusely hypo-intense, and the myocardium, which should be normally bright like this, was as dark as this. This was iron overload cardiomyopathy. Again, this was something that she had in the family going over for many years, and cardiac MR was able to recognize this, and then she got started on chelation therapy, and she's doing well following that. Another case scenario, this is a 23-year-old male, again, multiple admissions with heart failure, no chest pain, LV dysfunction on echo. There were two patients. The first patient also had that. This is a sibling of the other one who had something similar. And you can see again here that the LV is grossly dilated. Again, there is mitral regurgitation in this case. And then when we do the functional analysis, grossly dilated, not much of edema. There was no infiltration in terms of edema at the time of presentation. And then we do this delayed enhancement. And in here, you can recognize what I had shown you earlier, the mid-myocardial enhancement, which is not that of an ischemic cardiomyopathy. And also you can see epicardial enhancement. There is enhancement along the outer surface of the myocardium. Now, we do have newer sequences, which are called as T1 mapping and ECV, or extracellular volume. What this does is, without the use of contrast, we can look for areas of fibrosis. At a very early stage, we can see fibrosis. This was a case of Becker's muscular dystrophy. These were two siblings who had similar, and there were lots of familial history in this case. Again, great case in terms of showing the degree of fibrosis, which basically puts them in a poor prognostic feature. And you can follow these patients up and institute them on the correct therapy. Again, familial screening that Dr. Barry was speaking about becomes important in these patients. And the T1 mapping that we spoke about is also something very useful in monitoring these patients and seeing what happens to them over a period of time. This is a paper from James Moon, a good friend of mine. What you can see here is, even without giving contrast, we are able to look at T1 values. So this is one patient about, let's say, 5-6 years ago. We would do a cardiac MR scan. We would do delayed enhancement imaging. There would be no contrast enhancement, and we'd say it must be normal. Then we realize that we are wrong at it. And now we have T1 mapping sequences. Even with a normal delayed enhancement, we are able to pick up early myocardial fibrosis. And you can see different pathologies where the T1 values are high. The two pathologies that you may want to know where the T1 values are low are Fabry's and iron overload cardiomyopathy. So these are kind of MRI parameters. So Fabry's is something we don't see that often in India, but T1 mapping really helps us in differentiating these patients. This is something very easy diagnosis, I would rather say, not commonly seen. Again, this was a patient who presented to us with heart failure. Echo had been done. Echo itself picked the abnormality, but what you can see are these large areas of non-compacted myocardium causing a non-compaction cardiomyopathy in this patient. So another digression from a standard dilated cardiomyopathy, you may be able to see these. And again, cardiac MR has got good diagnostic features in these patients and can help. One thing which often gets confused or does not get picked that well is a infiltrative cardiomyopathy or restrictive cardiomyopathy, like an endomyocardial fibrosis. This is one such patient where you can see biventricular endomyocardial fibrosis, which if echo is not done properly can be missed, but there is great evidence of a restrictive physiology, and you can see biatrial dilatation with MR and TR. This brings me into another very interesting one, as Dr. Barry was saying, about cardiac sarcoid. Okay, we do see this often, and again, the standard imaging protocol in our institute is to do a cardiac MR and also a PET CT for these patients to look at the different phases of inflammation. So this is a patient who's got small mediastinal lymph nodes, and we can see these patchy areas of abnormal enhancement. And again, the T1 values were raised and ECV was raised. This patient presented as an acute myocarditis, and this was proven to be sarcoid. One entity that we all come across is a dilated heart with preserved myocardial thickness. And this is what you see in delayed enhancement, diffuse subendocardial enhancement, like a zebra pattern, we call it, white, black, white, in a patient with cardiac amyloidosis. Again, in patients who have cardiac amyloid and renal involvement, and if they cannot have contrast, T1 mapping itself is sufficient in most of these cases. So we can do a cardiac MR without contrast and tell with a decent confidence that this patient has got cardiac amyloidosis. Also, depending on the amount of enhancement and the pattern of enhancement, it is possible to differentiate AL and ATTR varieties of cardiac amyloid, not to 100% confidence, but to a reasonable confidence in patients who you are not able to get a tissue sample on. Let me jump into prognosis. Well, the simplest thing to remember with cardiac MR is anybody, any pathology has delayed enhancement or late gadolinium enhancement does worse compared to one who does not have cardiac MR, who does not have delayed enhancement. So if you can see, this is like a transmural enhancement of the myocardium. This is a non-viable tissue. This patient will do worse off compared to this patient who has not that much of enhancement, but has got an intermediate infarct in this place. Similarly, if you look at the evidence, the presence of LGE predicts the all-cause mortality and any cardiovascular mortality. And the more the degree of scar, it is worse. And we are able to quantify that as well on today's date to help you in deciding which way the patient should be managed. Some of the acute heart failure symptoms, acute myocardial infarcts also, when you're looking, this is a patient who came in with an acute infarct. This is the myocardium at risk on cardiac MR, and we can see the degree of enhancement in these patients. It will help us to say whether these patients will have adverse remodeling or not. This is a patient who's got a microvascular obstruction as part of acute presentation. And this again is a poor prognosis in there. So if you've got a patient with renal dysfunction and you really cannot give contrast, you can't do a catheter angiography, we can't do a CT also, MR is very, very good, especially in two scenarios, one being a thalassemia patient where we can assess for iron overload without contrast, two being amyloid or any other infiltrative cardiomyopathy where we can turn around and say, are there any poor prognostic features or not? Management-wise, ischemic dilated cardiomyopathies, cardiac MR is very good in managing, guiding management in terms of saying, this is a transmural scar, please don't go and revascularize this patient. Well, this is a subendocardial infarct, and this patient should have revascularization and will do well. On the other hand, these are some of the beautiful things that cardiac MR can show. So this was one of the patients who's got this large aneurysm, which will be very difficult to depict to the cardiac surgeons, who can then plan and say, okay, I know what I'm doing. I can reduce the volume. I can do an LVRS or not. And again, if you can do a DORS procedure in these patients. So with cardiac MR, it is possible to clearly depict the anatomy of the ventricle and tell about what needs to be done. The last case scenario I want to talk about is the scenario of looking at the pericardium and saying, hey, I'm not sure whether this is a restrictive or constrictive pericarditis. Again, MRI is very, very good in differentiating these two pathologies. So this is one patient who's got this pericardial thickening. and you can dynamically look in the short axis. As the patient takes a deep breath, you can see a paradoxical septal bounce in this patient, confirming that this patient has got early constrictive pericarditis, which is again a very useful technique for us to look at in MR. Talking about challenges, the adoption of cardiac MR in India has not been very, very wide. There are few centers of excellence in each city who are doing some brilliant work, but many other centers or many other cities do not have the expertise either in the technology or in the radiologist or cardiologist who can report these cases. So it is like a chicken and egg scenario where the referrals come from the cardiologist that makes the radiologist or imagers train themselves. And as more and more technology becomes available, it will be positive response that we see more and more patients getting cardiac MR. The referral bias is also highly significant. For example, if you look at North India, if one of the hospitals, without naming it, the most common indication for cardiac MR in that hospital is suspected myocarditis. Similarly, in our hospital, we do not do that many imaging of myocarditis at all. They get clinically managed rather than getting cardiac MR done. So there is differences in referral pattern for cardiac MR, but the cost happens to be a major limitation factor for a lot of people, and time of MR, it's about 30 to 45 minutes it takes to do a proper cardiac MR study. But once you do it, the advantages of cardiac MR is that it is a one-stop shop. It will give you all the information that you want, the diagnosis of heart failure, diagnosis of dilated cardiomyopathy, the cause of cardiac dysfunction, the degree of dysfunction, and also be able to differentiate one pathology from the other with or without contrast. So in my personal opinion, as Dr. Barry had just shown in their algorithm, every patient, the first time they come in with heart failure, should have a cardiac MR as part of their normal diagnostic workup. Thank you very much again for giving me this opportunity.
Thank you, Dr. Vimal. It was a great, brilliant talk as usual from you. And so let's dive into the questions now. We have a few questions from the panelists. This is to Dr. Barry from Dr. Ravi Kumar. The first question is, do you know of any documented studies in your experience of how many dilated cardiomyopathy cases prove to be of viral origin?
So yeah, that's a great question, and it's really not well delineated. So, you know, there's probably a lot of, you know, especially as we hear all these COVID patients that are getting cardiac MRIs and finding asymptomatic or minimally symptomatic inflammation. Similarly, if you take children that have routine viruses and you put an EKG on them, you'll find abnormalities in a pretty high percentage of those patients. So there's a lot of myocarditis that we're probably missing. But to answer your question in terms of the percent of patients that are viral myocarditis, we don't know. We know there's some autopsy data that, you know, small series from Israel that shows it's about 16% of young people that are under 40 that die suddenly. So it depends what population you're getting. But if you take all comers for DCM, we really don't know. There's a lot of the competing theories between genetics and viral myocarditis is not well known, and we don't have a good gold standard. The Dallas criteria is a very, very poor gold standard. The biopsy sensitivity is at best 60%, so it's really a challenging classification question. So we don't know the answer to that.
Right. Thank
If
you.
I may add, can I add from my Indian experience? Well, I see one of the studies which was done was by Dr. K.K. Talwar in All India Institute, focusing on this aspect, because we see a lot of cases of dilated cardiomyopathy. For example, in our transplant, about 40-50% cases, but they're all, of course, when they come to the late stage. Dr. All India Institute, Delhi, they did a study and they found, of course, these were intermediate or late case, just about 5% or 8% had viral crude particles. Rest of them, there are some cases of giant cell myocarditis. So that means in the where we get it, we don't get proof of a viral origin, when we see these patients. But there might be possibly a viral etiology.
Yeah, and just to add to that, I mean, if we're doing a biopsy, that there is more of a push to send a sample to do viral PCR to look for the common viruses that can cause cardiomyopathy. But no one knows what the sensitivity of sending one sample for a viral PCR is. So even if it's negative, it's hard to interpret.
Another question is, do you know of any association of laminopathies and arrhythmias or AV conduction defects?
Yeah, there's a definite association between lamin AC and conduction defects, and starting with arrhythmias before the onset of cardiomyopathy. So that should be a clue to lamin AC. If you see the conduction defects and or atrial arrhythmias that precede cardiomyopathy, that should be a clue that you should consider lamin AC, and I would do genetic testing on that patient.
Well, again, in Indian experience, again, there's a study from, again, All India Institute 2015. And we also done a few cases, about 20 cases of genetic testing. And we have found about 25-30%, interestingly, of one LMNA, that is a laminin-related gene. And about, I think there are other genes like tritin or titin-related, a few of them. But the LMNA is a laminopathy, and as far as literature goes, it's associated with arrhythmia as well as conduction defects. So beta blockers and other drugs should be used very carefully in such, because we have a tendency for using carvedilol and other metaplor, heart failure. But these cases possibly it might lead to problems. So this is Indian experience, and we have done about 20 cases. Again, this LMNA has cropped up in about maybe 20%. So this gene possibly is there in it.
Yeah, and just to add to that, to do due diligence to Dr. Raj's talk on the use of MRI, I think if you have a patient that has conduction disease, you certainly, that would be a patient that, in addition to lamin AC, you should think about infiltrated diseases, especially sarcoidosis, amyloid. So that's where MRI becomes very helpful as well.
Right. So in the same context, my question is to Dr. Bimal Raj, and I just want to know if there are any specific MRI features for these laminopathies, DCMs?
To be honest, no. When you look at these, the few factors that we have seen in these patients tends to be a generic increase in T1 values, but we are not seeing any specific parameters which we will be able to differentiate one from the other. Even if you take, not similar to these, but if you take, for example, the Becker's and the muscular dystrophy patients, we had a family of 3 brothers. All the 3 had, the only common factor they had was they were DCMs. And MRI, the enhancement patterns were so different in all the 3 of them. Some had mid-myocardial, some had transmural, some had epicardial. So, and all had T1 values which were raised. So in a manner that, yes, we can say it's abnormal, but what is the cause of abnormality and differentiating one from the other is sometimes not possible. So with all these laminopathies, we don't have any characteristic MRI features.
Thank you. Dr. Barry, another question to you. Could giant cell, in your experience, could giant cell be tuberculosis too, due to tuberculosis?
No, I've never seen that or had any data to support that. There's not, it's thought to be autoimmune and T-cell mediated, and it responds very well to T-cell therapies.
In Indian experience, there have been about a few percent of cases, I won't say very rare, that's been reported from Hyderabad by Dr. Narasimhan. Some of them, they found caseating granulomas. So that means, just let me point out, if you do a EM biopsy in a case of giant cell versus sarcoid versus TB. So giant cell and sarcoid might look similar because both have some giant cell features, but sarcoid doesn't have a necrosis, myocardial necrosis. But this study from Hyderabad found in Indian circumstances, especially already some of them had history of tuberculosis. Surprisingly, about 10% of cases had tuberculosis and responded to anti-tuberculosis therapy. So we don't know how to use it in clinical practice, but you have a high index of suspicion of TB, then possible is possible. So one of the rare causes possibly. Maybe a large study should be done, but we have small studies.
In the same context, do you, so in such cases, do you give both antitubercular therapy as well as add the sarcoid therapy to those patients and put them on an ICD, or how do you?
Well, such one case which we manage responded to steroids and ATT. And of course, rest of the therapy depends on the clinical presentation of the type of intermax. So basically, we go by what is called as intermax classification in cardiac failure. So the patient is stage 1, 2, 3, they're very sick, so they need some kind of mechanical ICU. But patients who are more stable possibly would go for medical therapy. ICD if there is a history of arrhythmias.
Right. Dr. Barry, another question to you. Echo-based strain imaging, is it useful for OPD-based assessment? What would be your indications for cardiac MRI referral?
I'm sorry, is strain rate useful for?
Strain, yeah.
For
is strain useful for an OPD-based assessment of dilated cardiomyopathies, and when would you refer them for cardiac MRI?
Yeah, so strain is useful in certain populations. Certainly, I use strain a lot in my patients that are getting chemotherapy to monitor for changes in strain that can predict the onset of a drop in systolic function. It's not, there's not a lot of areas where it's super useful for diagnosis. For amyloid, the apical sparing is helpful, but certainly not highly specific. So it's additive, but it's not really commonly very helpful in making the diagnosis. MRI, like Dr. Raj mentioned, we have a very low threshold for MRI. If it's feasible, we try to get for any new onset dilated cardiomyopathy after we've excluded coronary disease, or if we sometimes will combine an MRI with with adenosine to do a stress MRI. But I try to get MRI on all my dilated idiopathic patients.
Would you ask them to do a stress cardiac MRI on all your dilated patients?
So I'll be interested to see what Dr. Raj says, but from my experience, it depends on my suspicion for coronary disease. If it's higher, I would do an angiogram, either invasively or non-invasively. If it's relatively low, then I could kill two birds with one stone. Then I'll add adenosine to the MRI just so I can kind of get the ischemic part ruled out. Although you'll also have, of course, a delayed gadolinium enhancement that will tell you if there's a large infarction. But this way, we can also look at the ischemic burden.
So we do have a protocol about this in a approximate manner. Aged 30 to 60-year-old patients with first presentation of dilated cardiomyopathy with nothing obvious, we tend to do adenosine in those patients. I do add a calcium score as an extra in CT for these patients because I don't want them to label as non-coronary artery disease if the stress comes back as normal. So we do say no significant ischemia, and if the calcium score is 0, then fair enough, we say no coronary artery disease as well. Above 60, it's usually a cath angio or a CT angio, then a cardiac MR in that order that we would do.
Okay, and what about Dr. Bimal? What about the state of strain imaging on cardiac MRI in India?
Strain imaging cardiac MR in India, there are 2 centers which are doing it, and there is one article very recently being submitted for publication, and I'm very interested to see what that comes out. We are not there yet in India. I think we need to be getting more centers working on it, but we are not there yet. Very promising results. I'm working with a team on artificial intelligence, which can give us strain data from our standard cine images. So I'm looking forward to seeing what results they come up with, because if that happens, then it is very easily accessible for everybody, and we all should be able to do strain imaging in there. But early days, I would say.
Thank you. So to Dr. Barry again, we're moving away from one-size-fits-all approach towards precision medicine, individualized therapies based on genomics. How often you do genetic testing in DCM, and are there any particular treatments based on genomics? This is from
so great question. So I think one, I'm part of an NIH study that's doing genetic testing on any idiopathic dilated cardiomyopathy, and screening their family members. So I do it often in the context of research, but now that that study is finishing up, I'm really starting to use it as an additive tool in all of my quote idiopathic dilated cardiomyopathy patients, even in the absence of a family history. I think if you have negative testing, it doesn't mean much, but if you have positive testing, that's an opportunity really to screen the family members, and that's the main benefit. So in terms of particular treatment for dilated cardiomyopathy based on genomics, we don't have that. It can be perhaps additive in prognosis, but we're still not even there yet. If you take the other, amyloid would be the one example where having a variant, so particularly if you have the Val142 isoleucine variant, that prognostically is the worst variant, so that helps you in that sense. And right now we do have 2 FDA treatments that are approved for the neuropathy of amyloid if you have a positive gene variant. I think a year or two that will be washed away and everyone will be candidates for those therapies. But right now that's the only therapy to my knowledge that's based on genomics in our field.
Thank you, Dr. Barry. So one to Dr. Vimal. Do you see any role of cardiac MRI in celiac disease with cardiomyopathy?
I saw that question, and I personally do not have an experience on that. I have not seen any specific cases of celiac related cardiomyopathy. So Ashita, if you know anything relating to that, I would be more than happy to hear from you.
There have been
yeah.
There are very few reports. One is from UK, in which they are reported as celiac disease with gluten intolerance and cardiomyopathy, reverted with stopping of gluten. I think it is very rare. I mean, maybe as Dr. Raj said, we don't come across, but has been in the form of case reports. Very rarely reported. I think Dr. Barry probably, if he has any cases, but they are of course going to be rare.
Yeah, I'm not aware.
And all right, so Dr. Dipali had a question for you, Dr. Vimal. Is it possible for constrictive pericarditis to recur post-surgery? And what imaging findings would you expect?
Thanks, Dipali. Great. So we've had about, I think, 3 cases which were constrictive pericarditis called up on CT/MR, went on for surgery, and about 6 months, 1 6 month, 1 3 month, and 1 about 2 years later came back with recurrent symptoms, and we were asked to image for them. One of them basically had a very, very focal area of constrictive pericarditis, especially in the back of the heart, the inferior aspect of the heart, along the AV groove, where we believe the surgeon could not get enough of pericardial resection done at that point in time. In all the cases, we had focal areas of recurrent constrictions. They were not large areas like we see in a native constrictive pericarditis, but they were very focal areas. We tend to start with a cardiac MR in these patients. And then once we find some constrictive physiology in cardiac MR, we would do a plain CT scan in these patients also to look for calcification. So yes, it is possible. I would do an MR to begin with in these patients and then add on a CT based on what the MR shows.
Thanks for that. Also, just one more thing. So once you remove the entire pericardium in surgery, then is it possible that the fibrotic changes that remain can mimic the pericardium? Is it possible?
Yes, you can have secondary inflammation in the epicardial fat, which can get adherent to the myocardial tissue or the epicardial tissue, which can give you that appearance. So if the surgeon is very confident that they have resected the entire pericardium, you're seeing very focal areas. And that's why it's focal. It does not give you a real constrictive appearance in there. So bad TBs can do that, especially with reactivation of TB, you can get that.
Got it. Thank you.
So this is a question to both the speakers. How often after MRI do you still not have a diagnosis, and what may be the reasons?
Yeah, I mean, I can start. I think that fairly often you still don't have a diagnosis. I mean, MRI is phenomenal for all the reasons that were mentioned before. Prognostically, it can differentiate very easily coronary disease from a coronary cardiomyopathy. And there are certain patterns. I mean, amyloid is certainly very high likelihood of being diagnostic with an MRI, but oftentimes you'll need to get tissue to figure out what type of amyloid anyways. But with other things like sarcoid and lymphocytic myocarditis and other types of inflammatory diseases, I think it's important to highlight this is not histology. So you will not have a definitive diagnosis, but you can have a suggestive diagnosis with a few exceptions. But for most diseases, it will be, that's why histology or other testing is really important.
Dr. Prabhakar Shetty, great question. How often we are without a diagnosis? So let me try and give you a slide of an anecdotal experience of this. If I do 100 patients with suspected cardiomyopathy of any cause in the Indian context in our hospital, what has to be understood is that a lot of dilated cardiomyopathy patients do not come to us, especially if they've got an established diagnosis by echo, cath angio, or some other modalities. The ones which come to us are often already tricky currently because not all DCM come to us. And do we find anything in them? In about 65 to 70% of cases, we do find something abnormal which guides in the one direction to go ahead. Diagnosis as such, I think, HCM perhaps burnt out, sarcoid suggestive diagnosis, amyloid perhaps yes in there, and myocarditis or ischemic heart disease. So I would say we point in the right direction in a lot of these cases, but a gold standard as in 100% diagnosis, we probably are talking about 35 to 40% in that.
Thank you. And I would agree with you too. Even in my experience in Jayadeva, it's kind of similar. All right. So the next question is to Dr. Barry. What is the experience of tafamidis for amyloid?
So tafamidis for amyloid is, there's a New England Journal paper published in 2018 showing that it has a 30% survival in patients with cardiomyopathy due to transthyretin amyloid, whether it's wild type or hereditary. And this is over a 30-month period. So it took a while. It takes at least a year for that separation in curves in survival. So it's not an immediate effect that the patients will have. They did have a benefit at 6 months in terms of improvement in Kansas City quality of life questionnaires or 6-minute walk test. So there is some clinical benefit at 6 months, but mortality, 30% benefit at 3 years. And it's very well tolerated, very few side effects, if any, but very expensive.
Right. Thank you. So one more question from Dr. Anand Subramaniam. When you see a patient first, how do you assess what stage of disease process the patient is in and likely the progression of disease, whether to recover or is he in a burnt out stage?
Well, ending with a tough question. So that I don't think there's one simple answer to that question. I think part of it depends on the etiology of their disease. I mean, certainly if it's amyloid compared to pericardium cardiomyopathy is very different prognostically. The time they've had the disease, certainly the longer they've had dilated cardiomyopathy, the worse. It depends if they've started medical therapy, you have to see how they respond to medical therapy. And then of course, still the most important prognostic thing that we can do is our New York Heart Classification, and then clinical exam as well. So that's a short answer to a very long question, but I think you have to assess the patient, treat them, and then continually, you don't treat them and walk away. You treat them and continue to follow them closely while you're trying to get them on the best medications. And a lot of them will do well with the best medications, but you have to monitor them and see them closely. And if they're failing medications, then you have to do more.
Does the size of the ventricle or any other parameter give you a rough idea as to what's likely to happen, or the echo features? Because I know that classically you would like to treat the patient, follow the patient up, see if he's making improvement, not making improvement. And I'm glad that we have CMR now to give us some prognostic evidence. But clinically or based on echo, do you get a gut feeling based on certain parameters? So that's what I was looking for.
Yeah, that's a great question. So I think if there's two different ways to answer that question. One is you talk about fulminant myocarditis. Those patients can have a non-dilated ventricle and they could go down very quickly and need to be supported. Now their prognosis may be favorable if they short-term respond to the therapies. But if you switching to the dilated phenotype and I think the type of patient you're asking me about, certainly, the more severe the dilation, that is, worse prognostically. However, if you look at the data from the CRT trials, looking at, they did CRT in patients with, 7, 8 centimeter ventricles, and they still, a lot of those patients recovered. So I wouldn't use the LV size as an indication or as a reason not to offer them all the best therapies and see how they respond to it.
So as a continuation of this question, when you see a dilated LV and you treat a patient and you see that the patient recovers, what degree of recovery in LV size do you expect? When you might see clinical improvement, you might see improvement in the ejection fraction, but what kind of recovery in terms of dimensions do you often see? Is there a rough guideline or a general idea that we can get by looking at the initial size and then to see when they recover?
Yeah, so great question. I think when we talk about heart failure with recovery, I think all the focus has been on ejection fraction and not as much focus on the LV size as perhaps it should be. But there's, really, I'm hoping all my patients will normalize their ejection fraction. That's the goal. And of course, the minority will do that, but a sizable number will. I have a clinic where I think about a third of my patients will have recovered ejection fraction. So I think the main focus is the ejection fraction. If that happens, the LV size should normalize. But if patients have, I don't know of any data to show a particular decrease in LV size would be prognostically mean X, Y, Z. But obviously, the more closer to normal, the better.
Dr. Vimalraj, that was a lovely presentation. I think you sold CMR to all the cardiologists who have any doubt about it. Those case presentations were brilliant. So could you throw some light on this question that I asked you regarding regression of LV size on recovery based on your CMR parameters? And the second part of the question, we often find ejection fraction is far lower on a MR as compared to echo reporting. So it's almost consistently always lower. So is there any reason behind it? Can you throw some light on that?
So I'll tell again something from my personal experience. As part of my cardiac imaging, I trained in echo and transesophageal echo. And one of the projects that I worked on together was to compare a single person doing an echo, MR, and a TOE in a patient cohort to look for ejection fractions. And what I found was, even me, I did estimate, as you said, the LV ejection fraction, especially in an abnormal heart, was lower on MR compared to echo. And one of the reasons that I could ascertain was the visualization of the LV was really not that good on echoes in these patients. And you are making a lot of presumptions in these hearts, which are not necessarily truly cylindrical in nature, which makes it a problem. Where MR, when you look at it, it is very much a complete 3D heart data set that you're able to see. On the other hand, you may find a lot of MR reports also have errors within them. Okay, I have seen a few of the MR reports which comes, for example, we do our MR, we look at the stroke volume of the LV and we make sure that's the same volume coming out in the aorta as an internal checkup for us. So we know what we are calculating is correct. But a lot of other units do not do it. And that may be a reason why you're getting volume measurements which are lesser than that. But if it's done by the same person in the same manner, I think it is to do with the shape of the heart. If you've got a normal patient, if you've got a normal, good functioning heart, I don't think that difference of ejection fraction will be that apparent in these patients. In terms of following up of patients and looking at the LV dimensions, two scenarios, especially patients post-chemotherapy. We have seen patients who've had chemotherapy-induced dilated cardiomyopathies. They tend to come back in normal sizes and the dimensions come back. But is there a tipping point beyond which they will not come back? That is not available. So for example, Dr. Julius keeps asking me when we talk about RV cardiomyopathy, if RV is not functioning well, if I fix the tricuspid valve, will the RV recover or not? Can you tell me that? And that becomes a very difficult question for us to answer because there are no clear-cut points where we say beyond this, this is not going to recover. So very similar to what Barry said, no, we don't have very clear-cut points on that.
I think just to add to that, I mean, just by going by the images that Dr. Vimalraj showed, the spatial resolution of MR is just so much better and more than echocardiography. And it depends on who does the echocardiography too, because a lot of places you have echocardiography done by technicians, and in overloaded places you may even have the EF calculated by visual assessment rather than quantification on echocardiography. And at least in many of the centers where they do a lot of CMR studies, it's usually quantified to precision. So, and correlated with flows like Dr. Vimalraj said, and basically to make sure that there is some internal check mechanism to make sure that where our contours are right too, because anyone can go wrong. So, I mean, consistently, yes, even that's one of the observations that our cardiologists have made. And even as, as an MR imager, even I have made, in fact, that, and I'm quite surprised when I get the EF to be equivalent to echo. So it happens the other way too. And then I'm like, rechecking mine and rechecking to see whether it is really right or, it's just one of times when the echo and the MR correlate with each other.
Can I add?
Yes,
Dr.
sir, please.
Anand, to answer your question, it's not the EF alone which determines heart failure. Of course, sometimes the clinical progression of disease might exactly correlate with the EF calculator. So that is why we also depend on biomarkers. The NT-proBNP, for example, is one of the good biomarkers to see the progress and the prognosis of the patient, which is very important in a case of heart failure. So imaging is one aspect, but again, the clinical progression, so biomarkers is one thing which is very important. NT-proBNP and ST2, both are now available widely, and we think that should be advocated by clinicians. Can I add 2 points before?
Yes, sir, please.
Yeah, see, in our experience in cardiomyopathy, Dr. Barry mentioned it in his list. There are some diseases which are very important, or etiologies which are very important. So number one is anthracycline cardiomyotoxicity. That means patient who is having cancer and has anthracycline. We sometimes see these cases ending up in advanced heart failure. And in my experience, even after withdrawal or stoppage of those drugs, anthracycline drugs, doxorubicin, etc., still there is no, the disease doesn't stop progression. We have done biopsy, of course, just to make sure it doesn't seem to make a difference ending in heart transplant. Other thing we also seen is what is called toxin-induced cardiomyopathy. So interestingly, we have seen some cases in which one case of hip replacement causing cobalt extrusion and cobalt cardiomyopathy. And of course, alcohol and other things are also there. And the third one is in ladies, women with peripartum cardiomyopathy. This is one problem which I think is significant. Sometimes we see young ladies and just relentless progression and ending up, in this, are there any therapies there, bromocriptine, other things? I'll ask Dr. Barry whether, I really don't know, because they just keep on progressing and end up in severe heart failure, about 50-60% of cases.
Yeah, just one comment on the anthracycline cardiomyopathy. I mean, certainly we see a lot of patients that have advanced heart disease due to anthracycline cardiomyopathy, and the ones that have it bad, you know, like you mentioned, do progress to the point with that beyond repair. The key is catching them early, and that's why you know, doing echoes in the summer, even doing MRIs with strain early. There's been data that if you use biomarkers like cardiac troponin specifically to monitor for toxicity and start treating those patients with an ACE inhibitor based on troponin, you'll be able to prevent the cardiotoxicity from adriamycin. So if you, and I have a lot of patients that because we catch it early within the first 6 months or so, they do have a higher chance of recovering. And there's a lot of great data from Italy with Daniela Cardinali, who's published on this, that if you're able to treat adriamycin cardiotoxicity within 6 months, you do have a good chance of recovery. But if you miss that 6-month window, very unlikely, and their experience was 0%. I take that with the greatest fault, because we have had a few patients, but a lot less likely to be able to treat. So you really have to follow these patients regularly.
And out of
yeah, one question for you, Dr. Barry, is how frequently would you cath a patient of heart failure and cardiomyopathy? Hemodynamic assessment. How frequently or how often do you do? Is it an early case or a case, for example, you start on Vimeda or what do you call Entresto? I mean,
yeah, we probably do it.
How frequently do you?
We probably do it too much, because we do it, we're advanced heart failure and we're used to doing it on all our patients. So we probably overdo it, to be honest. But I think a new onset, if they're, I think you try to get them to respond to therapy. I will cath them if I'm thinking about whether they're candidates for LVAD or transplant, and they'll all have a right heart cath if that's the case. But in other populations, it's really if they're failing therapy, or if I'm wondering whether we should do something more. But if I know that they're volume overloaded, I'm going to treat them with diuretics and afterload reduction.
How frequently do you do EM? Sorry.
No,
how frequently do you do EM biopsy?
Fairly frequent. So I mean, obviously in our amyloid, we have a large amyloid population. So those, that's the best spot for us to get tissue in most of these patients to make a definitive diagnosis. So we do it often for that, often for post-transplant, but for new onset diagnosis, we just the top of my head for sarcoid and lymphocytic myocarditis, and for idiopathic DCM, we probably do, I'd say maybe 50 a year.
Right. Actually, just want to share a little bit of about my personal experience with chemotherapy-induced cardiomyopathy. So we've just published a study on trastuzumab-induced cardiomyopathy and RV, and it affecting the RV, and it was a CMR-based study. And basically, what we found was that and most of these patients were actually asymptomatic. And we don't tend to follow the RV as much in chemotherapy-induced cardiomyopathy. And what we found was that RV kind of followed the same trend as the LV, since it's a type 2 reversible cardiotoxicity caused by trastuzumab. The RV also went down and then recovered at 18 months. So it was a longitudinal study that we did. And I mean, this is very, very subtle changes in EF. And just as rightly Dr. Anand pointed out, that that echo kind of shows overestimates the EF, or MR underestimates the EF, whichever way you want to look at it. Echo is not going to be able to assess the subtle changes in EF that you would want it to you would want to know in order to catch these patients really early. So I think CMR these patients would really benefit from CMR, especially when you want to catch these patients really early. So another question based on post-chemotherapy patients. So for Dr. Barry, for post-chemotherapy patients, do you think strain rate imaging is helpful even if LVEF has recovered or LV dysfunction has started?
So I think that the main benefit of strain in this population has traditionally been monitoring for the risk for getting cardiomyopathy. So if they have an abnormal strain while you're monitoring them, then they're more likely to have cardiomyopathy. Once their EF's dropped, I don't find strain particularly helpful. We are also looking at publishing some data that we have looking at the baseline strain. So if your baseline strain is abnormal, then you do have a higher risk of having a cardiomyopathy subsequently. There's been some data on that as well. But so once they've dropped their EF, I don't think it's particularly helpful. I think there's hypothesis generating that if you recover your EF but still have an abnormal strain, those patients may do worse than those that recover their strain as well. But I don't know of any data that shows that.
So I guess that brings us to the end of this wonderful session and our final session.
On behalf of HFF, we thank Dr. Barry Trachtenberg and Dr. Vimal Raj for giving excellent talk on dilated cardiomyopathy. It was really informative and it will help us for day-to-day practice. Hope all our delegates enjoyed this talk. And we also thank our panelists, Dr. Ashita and Dr. Ravi Kumar and Dr. Anand. And I thank all delegates for attending in large number for making it very successful. And also I thank my colleagues, Dr. Karthik and Dr. Bhagirath, and also Sheshadri from Hallmark for organizing this event. Thank you very much. And from HFF, we'll be back in 2021 with more exciting topics. Thank you.
Thank you so much.
Everyone, thank you so much.